We are just going to start because they are getting the YouTube link on. On हो गया? Very good afternoon, everyone. We again welcome you to a session of Cuddles online neonatology educational series. Myself, Dr. Aparna. I take care of the NICU at KIMS Cuddles, Kondapur. And today's session is going to be all about human milk fortification and the rationale, the different techniques of fortification, the different available preparations for human milk fortification with their relative pros and cons. And a little bit about evidence on human milk fortification, multi-component fortification, recent evidence as well, and something about a practical guideline or a practical policy for practical implementation of multi-component fortification in preterm growing babies. So the objectives of today's discussion would be the following. We'll be discussing all the questions: why, how, when, whom to fortify, and what is to be used for fortification. We'll also be discussing in brief detail about the current updated evidence from systematic reviews on multi-component fortification of human milk. And we'll try to wind it up with a practical policy of how we can go about fortification in our NICUs. So let's begin with the rationale of fortification. All of us who are dealing with preterm very low birth weight newborns know that there is absolutely no controversy that mother's own milk is the best milk for any premature baby, or for that matter, any term newborn as well. So the World Health Organizations have made a strong recommendation that the most preferred choice of milk in any preterm baby, very low birth weight baby, would be mother's own milk or mother's own human milk. When this is not available, the next best option would be donor expressed breast milk. And this is relevant to those settings where appropriate human milk banking facility is available. This word of caution has been specially mentioned because of the small but significant risk of some viral infections, particularly congenital cytomegalovirus viral infection that may be transmitted by the use of shared human milk without pasteurization. The next best option when both mother's own milk and pasteurized human donor milk would not be available would be the use of preterm infant formula or the enriched supplemental feeding. In other words, this is calorie and protein enriched formula. So although the World Health Organization does not strongly recommend the enriched infant milk substitutes over standard or term infant formula, this may be considered because of the higher calorie and protein content in enriched formulas, and this may especially be relevant in those babies who have poor weight gain on standard formula, or in some units, this may still be a policy wherein this may be routinely used in very low birth weight neonates. So in our unit, if one does not have access to both mother's own milk or donor expressed breast milk, we do use enriched formula. The last option would be standard or term infant formula. This is applicable for newborns, babies weighing more than 2,000 grams at birth. Now, why are we discussing about fortification today? This is the main rationale that despite maximal consumption of human milk, of unfortified human milk, most of the macro and micronutrient demands of a preterm very low birth weight neonate may not be met. So to put this in context, this table actually shows us the macronutrient requirements or recommendations made by ESPGHAN, and two recent recommendations have been put down in this table. One published in 2010 and the other recent update published in 2022. So let's look at the 2022 recommendations. A preterm very low birth weight newborn requires 115 to 140 kilocalories per kilogram per day. Now, with an average calorie content of preterm human milk, mature milk, at 67 kilocalories per deciliter or per 100 ml, even at a maximal intake of 180 ml per kg of unfortified human milk, one would be only able to provide around 120 kilocalories per kg per day. In terms of protein intake, the recommended protein supplementation for a preterm very low birth weight baby would be 3.5 to 4 grams per kg per day, which can be anything up to 4.5 grams per kg per day in an extremely low birth weight neonate below 1000 grams. At an average content of 1.4 grams per deciliter for preterm human milk, one would only be able to supply around 2.5 to grams of protein per kilogram per day, even at 180 ml per kg per day. Similarly, maximal intake of unfortified human milk may fall deficient in a few important micronutrient supplements as well, as has been summarized in the upcoming slides. So although we may be able to provide reasonable quantity of calories, which may just fall in the low normal range of the ESPGHAN recommended guideline at around 120 kilocalories per kg per day, we all know that in a special group of high-risk babies, like babies with bronchopulmonary dysplasia, with increased respiratory demands, the required volume, the required quantity of both calorie, protein, and micronutrient supplementation may be on the higher side, and hence unfortified human milk may simply fall short of the nutrient demands of the baby. This table again summarizes the recommended intakes of various micronutrients as per ESPGHAN. So vitamin A, for example, which is recommended at an intake of 1,330 to 3,330 units per kilogram per day. When we look at unfortified human milk at maximal intake, still is provided at around 689 units per kilogram per day, and this grossly falls short of the recommendation. So this is also true with vitamin D, vitamin K, calcium and phosphorus, iron and zinc, and in fact all except vitamin C in terms of micronutrients would not be met with unfortified human milk. And this is the main rationale for multi-component human milk fortification. Now, when you look at calcium and phosphorus, the recent ESPGHAN recommends 120 to 200 milligrams per kg per day of calcium, and roughly 50% of this quantity in terms of phosphorus, and both of these grossly fall short in the maximal volume of unfortified mother's milk. And providing adequate macro and micronutrient intakes has definitely been shown to improve the in-hospital growth, as can be seen in this elegant study published in 2016, which looked at 3 periods of time, wherein the most aggressive nutritional regimen, which provided maximal intake of calories and proteins, kind of translated into significantly better weight gain, as can be seen in this first box and whisker plot. The average mean weight gain, as well as the average length and head circumference gains were definitely directly proportional to aggressive supplementation of both macro and micronutrients. So hence, it is very clear that providing optimal intake of the recommended quantities of dietary allowances seems to have definitely an important impact in the in-hospital growth, and possibly an impact even in the long-term neurodevelopmental outcomes. And hence, we come to the question of fortification. And here we shall be discussing about different approaches to fortification. Now, what we all have been doing for many years is standard fortification. This is the standard or uniform technique that is mostly used in Indian units, which is fortification, fixed amount of fortifier being added to a fixed volume of human milk according to the manufacturer's instructions. The most important advantage is that this is very practical. This is easy for us to remember. However, an important disadvantage is it doesn't solve the problem of protein undernutrition, as we shall be seeing in the subsequent slides. Now, despite standard fortification, it has been seen that very low birth weight infants may continue to have growth faltering or suboptimal growth. The important reason for this is that standard fortification still does not meet the required macronutrient demands, particularly for the recommended dietary allowance of protein. So hence comes the question of individualized fortification methods, wherein we have 2 different techniques. One is adjustable fortification, the other technique is targeted fortification. So what is the difference between the two? Adjustable fortification primarily targets chasing or tracking protein adequacy, which is monitored by measuring blood urea nitrogen levels twice weekly, cutoff of which is 10 to 16 milligrams per deciliter. So if in a given preterm baby, one finds that the blood urea nitrogen levels are below 10 milligrams per deciliter, additional protein fortification is added to human milk in addition to standard fortification. And if in case BUN levels are more than 16 milligrams per deciliter, the strength of fortification would be cut down. That is, if we are giving full strength fortification, we may cut down to half strength fortification. Now, although fortification techniques, adjustable fortification may be practical, it kind of requires close monitoring of blood urea nitrogen levels. However, this is still easy because it does not require expensive devices. It simply requires regular measurement of blood urea nitrogen levels. It safeguards also against excessive protein intake. And we shall be seeing in terms of real-time evidence how this has been shown to optimize growth and protein intake in preterm babies. The other strategy for individualizing fortification is what we call as targeted fortification, wherein macronutrient concentrations in human milk are analyzed based on a human milk analyzer. And based on these results, milk is supplemented with additional protein or fat. So, for example, if you find based on human milk analyzer that mother's milk contains a much lower content of protein, for example, 1.1 gram per deciliter instead of the assumed 1.4 or 1.5 grams per deciliter in preterm human milk, then this would call for additional supplementation of protein based on the actual content of protein in human milk. So this, however, requires that bedside human milk analyzers are required, which are quite expensive, and they also are labor intensive. And here in this strategy, supplementation is done according to the population recommendations and does not take into consideration that each individual infant requirements may be different. So standard fortification, as we all know it, typically implies the addition of one standard sachet of the human milk fortifier that we get commercially to 25 ml of mother's milk. Now, the problem that we already discussed with standard fortification is that it does fall short in providing adequate protein intake. So when you look at the actual protein content of preterm mother's milk, which may be roughly around 1.4 or 1.5 grams per deciliter, addition of human milk fortification does marginally increase the protein intake, and one may end up achieving something like 2.8 to 2.9 gram per kg per day at maximal volume of say 180 ml per kg per day of fortified expressed breast milk. However, we know that in utero growth, which is targeted as the ideal growth for the preterm infant, can only be reached with adequate protein and energy intakes, and protein intake particularly plays an important role. So the standard fortification assumes that human milk protein content is quite uniform at around 1.4 or 1.5 grams per 100 ml of mother's milk. However, this is not absolutely true, as we shall be seeing in the subsequent slides. Human milk protein concentration is quite variable, and it can drop to around 1 gram per deciliter by week 4 to week 6. So these are two figures that demonstrate variation in preterm human milk content of protein as well as calorie. So protein is represented in the picture on the left side, and calorie is represented on the picture on the right side. So we can see that there are multiple lines representing the actual protein content distribution in preterm milk as well as term milk. So the kind of the age line that is shown over the x-axis is represented here from 0 to 12 weeks. So you can appreciate how the breast milk protein content, which starts off with something as high as, say, 3 or even 3.5 grams, very quickly drops to around 1.5 grams per deciliter by the second week, and it might drop down further to around 1 gram per deciliter by the end of the 4th to 5th week, and kind of plateaus somewhere there. So based on the assumption that preterm breast milk has around 1.4 grams per deciliter, a strategy of standard fortification or standard addition of fixed amount of human milk fortification may not really account for the fact that maternal human milk protein content can actually drop down significantly further in the subsequent weeks. The slide on the right side actually shows the calculated energy estimates distribution of preterm and term breast milk during the first 12 weeks of life. And you can see that this is fairly kind of standard. So this not only results in inadequate protein intake in the preterm very low birth weight newborn, but this can also kind of translate into a suboptimal growth, as you can see here in this study that was published in 2013, when the investigators compared the median growth Z score, so wherein the baseline line represents 0 Z score and the lines to the bottom represent negative Z scores. So it has been clearly shown that despite taking the baby being on more than 75% intake of fortified human milk, this really did not prevent a fall in the Z score, the mean Z score for weight for age, at around day 28 of age, although most of the infants managed to catch up by the time of discharge. So whether or not the infant received less than 25% of fortified human milk versus more than 75% of fortified human milk, there was a significant drop in the Z score as defined by weight for age, in terms of their standard deviation. So there was a significant dip in the short-term anthropometric parameters, particularly weight for age, despite a strategy of standard fortification for the reason that we just discussed. It does not account for the fall in preterm human milk protein content over a period of time. So this brings us back to the techniques of individualized human milk fortification, and we shall be discussing a little bit more in detail about adjustable fortification. So adjustable fortification, which is a technique wherein one targets the measurements of blood urea nitrogen twice weekly, targeting a number of 10 to 16 milligrams per deciliter, has been found to be one of the more acceptable options or techniques of fortification, offering some advantages over the standard fortification. Now, how adjustable fortification works is as follows. So once the baby is established on complete fortification, which means one sachet of HMF is added to the regular 25 ml of human milk, the infant's blood urea nitrogen levels are tracked twice weekly. So if blood urea nitrogen levels remain between 10 to 16 milligrams per deciliter, the same strategy of fortification is continued. If blood urea nitrogen levels drop to below 10 milligrams per deciliter, one may have to increase the strength of fortification, wherein after full strength fortification, one would still want to add an additional protein supplement at the rate of initially 0.4 grams per 100 ml of human milk. And if this still fails to establish blood urea nitrogen levels within the target range of 10 to 16 milligrams per deciliter, one would keep increasing the strength of the protein supplementation in terms of doubling of the concentration from 0.4 to 0.8, and then this would be further increased as if the baby persistently has decreased blood urea nitrogen levels. The strategy of decreasing the strength of fortification is also true. So particularly if you see that BUN levels are more than 16 milligrams per deciliter, that is if they are elevated, full strength fortification would be cut short to half strength fortification. So essentially this means that if one is adding one sachet to 25 ml and they find that BUN levels are more than 16, you may start adding half sachet to 25 ml. So this kind of accounts for the fall in maternal protein content, which happens over a period of time. And it also kind of safeguards against excessive supplementation of protein that can also sometimes happen, especially in the first couple of weeks. So does clinical evidence show that adjustable fortification is better? We have seen that physiologically, it seems to be plausible that adjustable fortification may provide higher intake of protein to the growing preterm newborn. But is this also something that has been substantiated by clinical evidence? The answer is yes. So this randomized control trial that was published in Journal of Perinatology 2012 looked at short-term anthropometric gains in babies who are managed with standard fortification on one arm and two different techniques of adjustable fortification. Now, when assessed on week 3, the infants who had been receiving adjustable fortification were getting significantly higher protein intake, which is something that is expected. And also the study showed that weight gain as measured by grams per kg per day, as well as length gain as measured in millimeters per day, as well as head circumference gain as measured in millimeters per day were both significantly higher in the adjustable fortification group versus the standard fortification group. And all these differences were statistically significant. Now, when we compared the three individual approaches, again, it was seen that both techniques of adjustable individualized fortification, that is adjustable as well as targeted fortification, were both comparable, and each of them was significantly better than standard fortification in terms of all three short-term anthropometric parameters: daily weight gain, daily head growth, and daily length gain. So it is definitely clear that a strategy of adjustable fortification in term either adjustable or targeted fortification is clearly found to be superior to the standard fortification technique. So far we have discussed about the rationale for multi-component fortification or human milk fortification. And secondly, we have discussed why techniques of individualized fortification are better than standard fortification. Now, next, let us discuss a little bit about when to start fortification of human milk. So here we would see two different terms. One is early addition of fortification, the other is the standard fortification technique. So way back when fortification was implemented as a strategy, it was generally begun at an enteral feeding intake of close to 150 ml per kg per day of human milk. However, later the cutoff volume at which HMF would be added was gradually dropped down to 100 ml per kg per day. Now, early fortification, although this was associated with an increase in the risk of necrotizing enterocolitis and feeding intolerance, and there were questions raised about feasibility, one had to also take into account that standard fortification was significantly associated with the risk of extrauterine growth restriction. So number of studies were performed comparing early versus standard fortification. Some of the important randomized controlled trials and their PICO kind of variables have been listed here. So the population of enrolled infants ranged from less than 1,500 grams, very low birth weight neonates, to neonates between 500 to 1,250 grams. The type of fortifier that was used also varied between bovine milk-based fortifiers versus human milk-based fortifiers. Now, an exclusive human milk diet, which utilizes the principle of using human milk added with a human milk-based fortifier, is found to also reduce the risk of necrotizing enterocolitis. But some of the early fortification studies also used a bovine milk-based fortifier, which would have been either a powder form or a liquid form. Now, while standard fortification typically was started at a volume of 100 ml per kg per day, or in some studies at around 75 ml per kg per day, early fortification was added much more earlier. Either it was added at between 20 to 40 ml per kg, or as early as the first express breast milk feed that was given to the baby. Some of the studies did not show any difference in the growth parameters between either early or standard fortification, whereas one study did show that there was an increase in the protein intake with the early fortification group, although there was no difference that was demonstrated in terms of growth. Our unit did perform a randomized controlled trial comparing early versus standard fortification, where early fortification was begun at around 40 to 60 ml per kg per day when compared to standard fortification at 100 ml per kg per day. And we did see that the time to regain birth weight was shorter with early fortification strategy. This was summarized in a Cochrane systematic review, a non-Cochrane systematic review, which was published in 2020. As expected, because of the small number of studies and the limited sample sizes, early as well as delayed or standard fortification, that is adding HMF at around 20 or 40 ml per kg per day when compared to addition at 100 ml per kg per day, did not translate into any significant differences in the short-term anthropometric parameters. But reassuringly, a strategy of early addition of HMF also did not increase the risk of necrotizing enterocolitis and feeding intolerance. Now, early fortification also meant that one would have to start adding HMF at very small enteral feeding volumes per feed, which could range between 4 or 5 or 6 ml per feed, especially in a baby who is born below 1,000 grams. And this would require special microweighing machines in order to calculate the precise quantity of HMF that needs to be added into this small volume of feeds. So we've discussed about early fortification, and there is some encouraging evidence to show that early fortification does not increase the risk of necrotizing enterocolitis and feeding intolerance, and may possibly result in improvement in short-term growth parameters. Let us now discuss the next question, which is about whom to fortify. The population of preterm infants that have been typically enrolled in fortification trials have been preterm infants born at gestation ages less than 32 plus 0 weeks of gestational age and or birth weight below 1,500 grams. Some studies have used slightly different criteria, which could be until 1,107.50 grams birth weight. This has been kind of listed in this small table here. The upper limit of the birth weight eligibility criteria in some studies extended even until as high as 2,000 grams, and these are all the studies included in the Cochrane meta-analysis of human milk fortification. The other important criteria would be that these were babies who were receiving either exclusive or predominant human milk, and not babies who are receiving preterm formula milk. So the last question that we are going to discuss is, what should we fortify milk with? Are there different types of human milk fortifiers? We have powder fortifiers, we have liquid-based fortifiers, although liquid-based fortifiers are at the moment not available in our country. Are there any new fortifiers? So we already know that the most preferred choice of milk in a preterm very low birth weight baby would be mother's own milk. So one study from AIMS published by Dr. Jeeva Shankar sir and his group was published in Journal of Pediatrics, and this looked at a strategy of fortifying human milk with preterm formula when compared to the regular strategy of using human milk fortifier for fortifying human milk. So the study, which included 123 preterm very low birth weight neonates, showed that there was no difference in the mean weight gain between the preterm formula fortified group versus the HMF fortified group. The mean weight gain was 15.7 plus or minus 3.9 versus 16.2 plus minus 4 grams per kg per day. So this was a non-inferiority trial. So it showed that preterm formula did not cross a pre-specified non-inferiority margin when compared to infants fed with mother's milk that was fortified with HMF. The important difference in the two groups that the study identified was that fewer neonates in the preterm formula fortified group had feeding intolerance, which was robustly defined in the methodology section. So the incidence of feeding intolerance was only 3.4% in infants who were fed with mother's milk fortified with preterm formula versus 14.3% in the group that was fed with mother's milk fortified with regular HMF. There were also fewer episodes of temporary withholding of fortification in the group that was fortified with preterm formula. So fortification with preterm formula was found not inferior in terms of short-term weight gain to the strategy of fortification with human milk fortifiers in preterm VLBW neonates based on this study. And the strategy also reduced the incidence of feeding intolerance and the need to withhold fortification. So preterm formula as a fortifier may turn out to be a very inexpensive or less expensive option when compared to traditional HMF-based fortification, because we know that 400 grams of preterm formula, which may cost around 800-900 rupees, may be much less inexpensive when compared to the regular HMF sachets, wherein 1 gram may cost anything like 35 to 40 rupees. The other novel fortifier that has also been evaluated in a RCT is a novel donkey milk-derived human milk fortifier. And quite surprisingly, the use of this fortifier was associated with lesser number of episodes of bilious aspirates and feeding intolerance as measured by vomiting. So finally, we have discussed a lot of different aspects about fortification, starting from the rationale for human milk fortification to the different approaches to fortification, such as standard and individualized fortification. We later discussed about whom to fortify and how early one can start adding fortification. And finally, we discussed a little bit about the novel fortifiers that have been recently evaluated. We shall kind of wrap up with evidence on the human milk fortification. And Cochrane meta-analysis has identified 14 randomized controlled trials. Most of them are small trials with significant heterogeneity. So the cumulative pooled effect is that the use of human milk fortification was associated with a slight increase in mean weight gain, which was 1.8 grams per kilogram per day greater in the group of infants who are given multi-component fortification when compared to a small increase when compared to the group of infants who were fed with unfortified human milk, but this was low certainty or low quality of evidence. Similarly, low quality of evidence also demonstrated slightly better mean weight gain in fortified infants, and moderate certainty of evidence showed that there was better head growth at 0.08 centimeters per week. So, although all these numbers are pretty small and it may not really convey much significance in isolation, when we kind of look at the cumulative gains in a baby who is born at around, say, 1,000 grams, these small gains in short-term anthropometric parameters may make sense because this may translate into something like 40 to 50 grams additional weight gain when you look at a ELPW baby over a period of 3 to 4 weeks. So there are very small gains in short-term anthropometric parameters with multi-component fortification. There is no significant increase in necrotizing enterocolitis, which is something which is very reassuring. Although the current studies do not demonstrate a significant difference in the long-term neurodevelopmental improvement, this absence of evidence should not be taken as evidence of absence of benefit, and hence every effort must be taken to provide whatever best possible strategy can be provided to the baby to optimize the baby's in-hospital growth. This Indian randomized controlled trial, which was published way back in 2007 from the PGA group, the primary author being Kanya Mukhopadhyay ma'am, also showed that a strategy of adding human milk fortification did result in significantly better weight gain, 15.1 grams per kg per day versus 12.9 grams per kg per day in the control group, and also significantly better increase in length as well as head circumference as measured in centimeters per week. A small word about available fortifiers. So the first column shows the absolute content of macro and some important micronutrients in human milk. This is mostly mature preterm human milk or term milk. Now, this is the existing content of various brands of solid fortifiers. There are two different brands that are available. There is another brand that is available in northern India, which we have not mentioned in this table here. So the calorie intake ranges between 3.3 and 4.35 grams calories per gram in the two preparations that are available. Protein content is around 0.3 grams per gram of fortification, and we also find the list of other macronutrients that are macro and micronutrients that are present in existing fortifiers. One brand also has added docosahexaenoic acid to the fortifier. Now, after addition of solid-based fortifiers to human milk, we can see that at 180 ml per kg per day of enteral intake, most of the macronutrients and micronutrient intakes are met. So energy intake with both the existing brands when added to the milk would reach 142 and 151 kilocalories per kg per day when you're giving maximal enteral volume of 180 ml per kg. This is definitely higher than unfortified human milk, which provides 120 calories per kg per day. Likewise, protein intake is also reasonably good at 4.2 grams per kg per day with the existing fortifiers. So with all the earlier evidence that we saw about the variability of human milk protein, both the commercially available brands have increased the protein content in every gram of their fortifier. Likewise, the targeted intake of fat as well as carbohydrate is also met with the existing brands of fortifiers. This is also applicable for vitamin A, calcium, phosphorus, iron, and also with DHA. One of the brands provides slightly lesser vitamin D intakes, and this is something that will have to be externally supplemented. In effect, one has to remember that there is actually no need to provide any other kind of single standalone supplements such as calcium or multivitamins when we are discharging a baby on 100% fortified human milk, when you're discharging your very low birth weight infant. So in terms of additional supplementation for various micronutrients, this is the general plan. So if we are dealing with a low birth weight baby, calcium supplements at 140 to 160 milligrams per kg per day of calcium, and roughly half this number of phosphorus is recommended from the time the baby reaches 100 ml per kg per day and is to be continued until term corrected age, which is 40 weeks of corrected age. And this is generally met with human milk fortification. Zinc, which is recommended at 1 to 2 milligrams per kg per day, is also something that is recommended after 100 ml per kg per day of enteral feeding, although there is no clear benefit or harm with the addition of zinc supplements. And this is also something that is met with HMS. So essentially, when you add human milk fortifier, one does not have to supplement additional calcium, phosphorus, or zinc. Now, when it comes to iron, it is generally recommended at 2 to 3 milligrams per kg per day, started from around 2 weeks of age. This is also met with HMF, but iron is recommended until 1 year of age. So after one stops HMF, one will have to add iron supplements. Vitamin D, on the other hand, again is met with one of the brands, but we just saw that with the other brand, one may have to add additional vitamin D supplements, and this is also recommended until 1 year. So once we stop HMF, we will have to add the vitamin D supplements later. The potential problems or worries with fortification mainly linger around the osmolality of the solution. So the osmolality of unfortified breast milk is around 302. This increases to around 390 with human milk fortification addition, and this is also the same with preterm formula. The most severe clinical manifestation of feeding intolerance is necrotizing enterocolitis, and there is no evidence that the risk of NEC is increased with increasing osmolality unless osmolality crosses more than 450 or 650 milliosmoles per liter. So this is what we follow at our hospital. We start fortification when the infant reaches around 100 ml per kg per day of enteral feeding with exclusive or predominant breast milk, and this can be also acceptable at slightly lower volumes as per NNF CPG. Now the recommendation is to begin fortification from 50 to 80 ml per kg per day. Now, whom to fortify? All preterm infants with gestational ages less than 32 weeks or very low birth weight neonates born with birth weights below 1500 grams are to be provided the benefit of human milk fortification. We generally do standard fortification, which is adding 1 gram of HMF sachet to 25 ml of expressed breast milk, but there is more and more evidence coming up on individualized fortification, and one does continue fortification until 37 weeks of postmenstrual age or until 2000 grams birth weight, whichever is later. The recent NNF clinical practice guideline statement recommends the addition of multi-nutrient fortification of breast milk in preterm low birth weight infants with birth weights below 1800 grams and those receiving enteral feeding at least 50 to 80 ml per kg. The human milk-based fortifiers are a new product that have come up in the in availability these days. They do have some disadvantages, particularly their lack of vitamin A, D, and relatively low concentrations of calcium, phosphorus, and even protein. But recent updates and recent revisions are being made in their content, and they have been coming up with incremental content of protein, fat, calcium, and phosphorus. So to summarize, fortification is an essential intervention or strategy to meet macro and micronutrient demands in preterm very low birth weight neonates. Individualized fortification technique may be better than standard fortification, and when we speak about individualized fortification, we refer to adjustable and targeted fortification. There is an evolving place for earlier addition of fortification from volumes as low as 20 to 40 ml per kg per day of human milk. Now, preterm fortifier itself as a novel fortifier is being evaluated and may have some advantages, particularly the relatively less cost. and lesser incidence of feeding intolerance, as was shown in one randomized controlled trial. And fortified expressed breast milk may still lack adequate protein, and this may call for the addition of a standalone protein supplement sometimes. So with that, I thank all of you for listening, and any comments, questions, please feel free to share them in the comment section. Thank you so much.